There's now really good data from multiple institutions that the timing of the chemotherapy, whether the patient gets it in the adjuvant setting or the neoadjuvant setting, is not an important factor in terms of local regional recurrence. So in the early days, when I think that the way that the surgery was performed, and sometimes there was no surgery performed, there was only radiation therapy if it looked like the patient had a complete response. The imaging was not what it is today. The pathology assessment was not what it is today. The local regional recurrence rates were higher. So there was concern that if you had a large tumor that shrank with neoadjuvant chemotherapy, that the patient was more likely to have a local regional recurrence rate. We know there are no differences in overall survival and disease-free survival whether the patient received adjuvant or neoadjuvant chemotherapy. And it's really the biologic factors that are important that are driving the outcomes. So those patients with ER-negative disease, with a large tumor burden at the time of diagnosis, and with a less than robust response to the therapy are the ones most likely to have local recurrence. Unfortunately, they're more likely to have local recurrence with mastectomy or with breast-conserving surgery. But we have more information now about how to select which patients are going to be the best candidates for breast-conserving surgery after neoadjuvant, and then also about the volume of resection. In the past, we weren't sure if you had to resect the entire tumor volume from that original size that the patient presented with, or if you could just hone down on whatever residual disease was left based on imaging. And now I think there are plenty of studies demonstrating that just targeting that residual radiographic abnormality is really the key. And then assessing the amount of disease burden that's still present in the breast.